Here in the ER, we've been having a tremendous problem with bed availability, and we're going to be talking today about some goals and some solutions to that problem from this point forward, how we need to deal with it. The goals of the presentation are long-term, and they really promote brainstorming as to how the availability of the ER can be improved in terms of our bed usage over time. We are to encourage new relationships with physicians and clinics to help deal with the volume in the long run. We are to find long-term solutions to aid in the staffing problems that we have and explore facility changes that are needed to keep up with the volume. We're also going to look at the objectives, and these are the goals that we have short term. They are to identify a solution for the problem of patients that are staying in the ER after they already have a bed assignment for the floor or the ICU, identifying a solution for waiting on housekeeping to clean a contaminated room, identify a solution for waiting on ambulances to pick up nursing home or orthopedic patients that have been brought to the ER, checked out, and we're waiting to return them back to the facility. Identify a successful way to keep and retain staff in the next couple of weeks, and identify any way that throughput can be increased by raising the number of treatment beds available. Now, the reasons that we have no beds we need to cover. Flu season. The ER is used as a primary care physician. Acute care clinics. Staffing issues, inadequate amount of treatment area for the volume seen, holding, floor, and in ICU patients, patients that are awaiting transport, and housekeeping is needed for room decontamination. One by one, let's look at these. How does the flu season affect our bed availability? The number of elderly patients means an increase in the number of flu cases that will progress to pneumonia and result in a higher level of mortality. Once the health of an elderly person is compromised, it's very hard for them to bounce back due to a weakened immune system. Many of them take steroids for COPD or asthma or another condition that suppress the immune system and make them prone to get the flu. Those that use the ER as a primary care physician, it's primarily for those that have no insurance, no money for a copay for a doctor's appointment, have no doctor at all, can't take off work, the acute care is closed, the doctor's closed on Fridays, it's a holiday, or my doctor is currently out of the country. As far as acute cares, the acute cares, we really need to look into if there's any reason they can't stay open later or open 24 hours. Because they close at 8 o'clock. Problem with acute care is if you don't have insurance, they're going to send you to the hospital. Now, things that are serious, they're going to go ahead and have you seen at the hospital, such as appendicitis or a heart problem. As far as reasons for ER use for ages 18 through 64, the research shows us that the main reasons that people used the ER were their doctor's office wasn't open, there was a lack of access to other providers, the type of insurance they required made them go to the hospital, such as ask a nurse, or they were referred by a doctor's office or a clinic. One of the main problems we have with staffing. The weekend. It's time to call out and have fun. How about the holidays? It's time to call out and be with the family. The fact that we are a military town means that turnover goes with the movement of the troops. The nursing shortage, period. People are retiring. Aren't they the lucky ones? Also, they're the new people that we bring in, but the new nurses don't stay. Just time they get some experience, they go out and travel. Next thing we need to look at are the inadequate treatment areas that we have for the volume of people that we see. We only have 4 psych beds. We keep psych patients for days. We keep rehab for drug and alcohol patients for days. State of Georgia is cutting back on the treatment facility availability that we have. The OBGYN beds that we have to check people that are going into possible preterm labor, we only have 4 of those. So what are we going to do about that? Isolation. We only have 3 rooms. 2 of them are really for observation areas. 1 is actually for the ER. Is that really enough for everything we have going on in the world today? Monitored beds. People with chest pain should not be in a hallway bed. They should be on a monitored bed. That's a problem. Complex lacerations need somewhere to sit while they wait for plastics or whoever they want to come in and fix their laceration, especially if it's on the face. What's the ER solution to everybody who doesn't have a bed? Let's put them in the hallway. way. That's not always feasible. Holding admitted ICU and floor patients. True story. 3 rooms were available in the ER to treat patients in a 10-hour wait in the lobby when flu season hit. We got the critical care diversion. We got more people coming in that need critical care than we have beds available or nurses available to treat them. We have 3 units in the hospital that have been permanently closed due to lack of staff. Patients that need transport. We have patients that are psych patients. We have the rehab and alcohol people. We have the ortho rehab patients that have fallen, have been checked out, and need to go back. Nursing home patients awaiting ambulance or family member to go back. Transfers to a higher level of care that are awaiting a ground or air transport. These are burns and brain bleeds. And children, if they're serious enough, then they get transferred to a pediatric hospital. Housekeeping. If housekeeping is needed for room contamination, it is usually for one of the following, but this is not an exclusive list: TB, meningitis, C. diff, Ebola, Zika, scabies, lice. Now here's some solutions for our bed crisis. Can we talk to the urgent care clinics about staying open later? Can we ask the local government if they can provide them assistance to do that? If they can give millions to a hospital here in the community to help the indigent, they should be able to help the urgent care clinics help us with the volume. We should provide incentives for nurses that will keep them wanting to stay. It's going to be hard to do when they can make $50 an hour in California, but if we can do anything to hold on to the new nurses, we need that new blood in our system because the old nurses are retiring. Talk to the former employees that have left and see if there's a pattern. Then utilize patient flow coordinators to prevent the bottlenecks where everybody just gets stopped up trying to get from one end where you're sitting and waiting to the other end where you're actually treated. We need somebody that's going to direct flow. The other thing we need to look at is maybe the solution isn't always to add more beds. In the current situation, it is when you walk in at 7 p.m. to 40 people waiting. Sometimes it's better to analyze the department resources and the patient flow to determine where enhancements can be made and eliminate the waste. How do you do that? Optimize the staffing. Use pivoting instead of triage. Pivoting means somebody walks in the door, you say, you need to go to fast track, you need to go to the main ER, but you don't spend 10 minutes on an evaluation. You just point them in a general direction as to where they need to go. Pull till full is utilized when there's any empty beds, and the results waiting area is used for what it's supposed to be used for. Instead of as a treatment area, it's used for people that are just waiting on results of tests. Let's address these goals, long-term solutions that we have. First, we're going to brainstorm on how to make the ER beds more available and how we can make it improve by posting your ideas to OneNote and then sharing your answers with my email at rnforahealthieryou@gmail. You're going to encourage new relationships with acute care providers, and you're going to help deal with the volume by working out a plan with them to stay open later, whether it's get the government involved, whatever we have to do to help them with the expenses, but help treat these folks, help us with the volume. Make an initial meeting at the conclusion of this presentation and then follow up consistently with a weekly meeting and update me weekly as to what the progress is going to be. Long-term staffing problems, get staffing that has at least a 2-year contract. You give them half of a sign-on bonus, then after the period of time that they work, you give them the other half. It's not that hard. It works. Plan and budget facility changes that are needed to help keep up with the volume and to increase the bed availability. Then in the short term, what can we do? We can look for the problem of patients staying in the ER. Use a patient flow coordinator. Make them force the flow through the ER to get these folks where they need to go. That person's job is to get them through the bottleneck and get them moved. The solution for waiting on housekeeping is better communication with housekeeping staff, and their supervisor has to instill a sense of urgency with them. The solution for waiting on ambulances to pick up nursing home or ortho patients to go back to their facilities: if you've waited 30 minutes for an ambulance, call another service. I don't care who we have a contract with. If they're not doing it, call another one. A successful way to keep and retain your staff in the short term: use a staffing agency. Use one that we've used in the past that has been successful with us. And make sure you contact them at the end of this presentation because we need folks now to fill the gaps. 8 nurses to staff an ER is what we had last night with 40 deep waiting in the lobby. That is not satisfactory. We need to get on this now. Throughput can be increased by raising the number of treatment beds available with the forced flow by the patient flow coordinator. This person isn't going to be a popular person. This person is going to have to expect a lot of resistance to change, but this person is going to be vital in getting this system to work and getting the kinks worked out and patients where they need to to go. People don't like to be pushed, especially when they're already strung to the very end. But that's what's going to have to happen for people to get where they need to go.